COVID-19 outcome. So I'm hopeful that that will come through as well. But I'm going to share a little bit of context with you about something that is on the data side, the technology side, the legal side of data, and combines all those things to try to meet a national public health purpose. And that's to try to get data from clinical care to public health agencies for their review and action. And that's what electronic case reporting is. It's the automated generation and transmission of case reports from electronic health records to public health agencies for review and action. And I'm going to tell you a little bit of a story about what happened during COVID. But first, give you a little bit of a background on case reporting. Every state in the country, every territory has case reporting laws, has reportable conditions that are named usually in a list similar to this one that's on the screen in front of you from California. This is a partial list of conditions that need to be reported to public health agencies when a patient is experienced that has such a diagnosis or such a condition. And a typical public health agency will have maybe 100, 130 that are reportable. A subset of those are nationally notifiable, which are presented to the Centers for Disease Control and Prevention as part of a notification system that's purely voluntary. There is no federal requirement for this reporting. This is all based in state reporting laws and reporting to public health agencies at the state and local level. You can see that there are conditions identified here, and there's a time frame under which they need to be communicated. And of interest here is that each of the states has different laws about what's reportable. So that's a problem immediately, because the new EHR vendors and the health information technology folks don't necessarily want to customize according to the jurisdiction they're in, and hence begins some of the complexity. But what happens typically, or was happened in the past typically, that with these reportable conditions were sent to the public health agencies via phone and fax. And there were some other electronic systems like entry into a web page, but that was about it. And HIPAA says public health is eligible to get these data. They are named data as reported to those public health agencies. And there's the core of the surveillance system that exists in this country. And it was not electronic really at the start of COVID. So public health had made efforts in electronic surveillance, and they included, for example, syndromic surveillance, where admission, discharge, and transfer data were shared because they were electronic, they were available. The ADT systems have been electronic for some time because they make billing more efficient, among other reasons. And so syndromic surveillance as a public health activity around trying to identify areas of concern had progressed over the years. Did not include identifiable data. Was what one could do with syndromic surveillance data, or what one can do, is pretty specific to looking at groups and looking at trends in populations. Similarly, electronic laboratory reporting advanced as a surveillance activity for public health because those data were electronic too. So lab information systems were electronic early, and public health hooked up with large clinical labs, national labs, and eventually hospital-based labs to get lab results directly and use them as a kind of surrogate for the status of the patient in regard to doing disease surveillance. Why? Well, labs were electronic early, and the data were accessible to use for these purposes. One of the unfortunate parts, ELR, as it's called and known in public health, was greatly helpful, has been for many years. But one of the unfortunate aspects of it is what you get in the end is a lab result, and only a lab result. And it's a lab result with data that are not necessarily what you need from a public health outbreak management or monitoring or reporting standpoint. And so I don't know if any of you saw this during COVID, but for example, to do contact tracing, the public health agencies at times needed better demographic data than were in a lab order that was provided to a lab. To do work with social determinants of health, or to do anything that related to race and ethnicity, was problematic because those data are simply not available in reliable form in lab results, partly because they were not available in lab orders. And so there were efforts during COVID to try to have what are called asked on order entry questions added to the lab workflow to try to get some of those data, but those always meet with only a limited degree of success. So enter into this world electronic health records. Most clinical practices and hospitals now have EHRs. And what electronic case reporting is the taking advantage of those EHRs to deliver data that are necessary for public health purposes and do it in an automated fashion. So this is a diagram we use when we're explaining electronic case reporting to healthcare organizations that we're onboarding. And it sort of lays out the flow, and I'll just walk through it for a minute or so. So on the left are electronic health records. In the middle is a APHL AIMS platform. It's a shared services platform that's supported by the Association of Public Health Laboratories and includes a decision support engine on it. And on the right are the different public health agencies, and all of the states and many large locals are connected up to this system to carry this out. So what happens is the provider of care in a hospital or ambulatory setting on the left in their EHR records certain data. There are 5 different categories of data: diagnoses, lab results, and others that when they're recorded in the EHR, they are looked up against a set of trigger codes. That's what's identified at the line at the top. And if there's a match, a case report is sent on. The eICR, electronic initial case report, is transmitted to the APHL AIMS platform. And then the decision support engine determines if that is truly reportable, and if so, to what public health agencies it needs to be reported. At the same time, a response transaction goes back, pursuing the sort of holy grail of public health agencies providing information back to providers of care as they so frequently ask for it. These are the broad contours of electronic case reporting. On the right, the public health agencies have surveillance systems. When this process is operative, the data flow seamlessly without the provider being interrupted in their workflow, and make it all the way to the public health agency surveillance system, where they are case managed, where they are put into monitoring of disease trends at the state and local level, and where they are voluntarily reported to the Centers for Disease Control Prevention as part of the nationally notifiable diseases system. So this is a little bit of a complex architecture, but the outcome here has benefits for both healthcare and for public health. So these reportable conditions are required by law, and at least ostensibly, providers are obliged by law to do reporting on them. Electronic case reporting takes care of those legal reporting obligations. The activity is supported by the Centers for Medicare and Medicaid Services, CMS, promoting interoperability program, formerly Meaningful Use. That's attractive to providers of care because they get credits for that, and don't have their payments dinged, or in the past during meaningful use, they actually got incentive dollars for doing that. This eliminates manual data entry and faxing of reports, which is problematic for healthcare organizations, and it's a burden. And there's a second step to that burden, which is when the public health agency gets those data, they frequently will have to follow up with those providers because they didn't get enough data to carry out the functions involved. And so two pieces of reducing burden here. One is to automatically do the initial report, and the other is to provide enough data that the public health agencies don't need to necessarily make as many follow-up demands on the public health agent, on the healthcare organizations to get the data that they need. And another benefit of this approach here is that it streamlines the jurisdictional reporting challenges. Remember, I said that each state has different laws of what's reportable. This system handles that for the public health, for the healthcare organizations by working through and implementing the laws. This decision support engine that I referenced earlier actually is authored by the public health agencies who input the specifics of their reporting laws so that the EHRs and the healthcare organizations do not have to navigate that variation that otherwise they would experience in that respect. This electronic case reporting also has benefits for public health agencies. So it involves the near real-time reporting of clinical case data. This is important in an outbreak. It's important in an ongoing way during routine times as well. The case data are used to support case management, disease monitoring, investigation. And what this does is really establish a near real-time connection between public health agencies and the healthcare organizations that they work with. And in many ways, the bi-directional communications that allow for information to flow in both directions to meet differing needs. So at the start of COVID, things were as I described. Case reporting was required by law in every state and territory, and mostly it was done via phone and fax, and not in an automated fashion at all. Bring on COVID-19. At the start of COVID-19, we had developed the architecture that I showed you for doing electronic case reporting, going through multiple consensus-based processes at a nationwide level. But we had, I think, 187 facilities nationally that were reporting, just 187. And the needs of COVID made clear to many why this electronic case reporting is so important as an infrastructure, and why accepting the use of phones, paper, and faxes for case reporting just doesn't work in a modern world. It is a legal obligation to do case reporting. It was not a legal obligation to do electronic case reporting. And yet at the same time, when implemented, electronic case reporting offers tremendous benefits for the healthcare organizations, as I've just detailed. The part of this that's so striking is that those of us who've been around public health for some time recognize that, in fact, outbreaks have happened before, they will happen again. COVID-19 was a major one, but it was not the only one in any respect. And SARS is represented in the contact tracing diagram that's on the right side of the screen. That was an outbreak that I was involved in when I was working at the Centers for Disease Control and Prevention. Fortunately, did not have a huge impact on the United States, but it's just one of, I would say, 10 to 20 that I was involved in and that had these same data needs from a management standpoint. So when COVID occurred, some of us who've been to this rodeo before recognize that at the same time that COVID was a very difficult time for public health agencies and for healthcare organizations, it was also a tremendous opportunity for them to move forward with infrastructure. And this is sort of the paradox of public health, is that during the emergency, public health has obviously many things to attend to, but it also has the attention of clinical care. It has monies that start to flow from Congress as a response to the emergency. And it is, in fact, a great opportunity to move forward, to advance the infrastructure. And so when COVID hit, we initiated what we called eCR Now, which is an initiative to advance electronic case reporting nationwide, and to try to do that during COVID, at the same time to try to meet some of the COVID needs. And this is a slide from April of 2020 that's on the screen in front of you, and was sort of what we kicked off with that initiative, which had several components to it. So a big part of this was a communication initiative. We were trying to express how data deprived public health agencies actually were, and to make it abundantly clear. And I, frankly, had never heard contact tracing be mentioned in the popular press as much as I did during COVID. You heard it frequently, and we capitalized on that and tried to make clear that these are data that we can provide through electronic case reporting to support those public health activities. And so we packaged up 3 elements to this initiative. One was onboarding providers rapidly. We teamed with some prominent physicians in the health IT arena, and we went to Epic user groups and other user groups nationwide and pitched them electronic case reporting, said it was a need, and also told them how they could do it. And Epic partnered with us early. They implemented electronic case reporting in their EHR, and we were able to onboard some numbers that I will show you in a minute during this process. We also developed a FHIR app, which we gave to EHRs that couldn't do electronic case reporting. So not all EHRs had the capabilities to do it, and we provided them an app based on the implementation of HL7 FHIR that all EHRs have to do by the end of this year. Many had already started on, and so we were able to provide this app to a number of EHRs, including, for example, Cerner, which has implemented it for and to have it available for their customers nationally. I mentioned the rapid onboarding in number 1. Epic was prominent in that regard. Between Epic and Cerner, there's estimates that they cover as much as 44% of all healthcare providers in their EHR implementations. But we didn't stop with those 2, but they represented significant successes moving forward. The other part of this was to develop a trust network nationwide that we could leverage to allow electronic case reporting to occur. These are sensitive data. They are legally required, but we need to have the infrastructure in place for them to be transmitted from the electronic health records all the way to the public health agencies, and needed trust networks to do that. So we partnered with the Ehealth Exchange, which is a nationwide health information network, also with Care Quality, and by virtue of Care Quality, Commonwealth. These are all big health information networks that helped us not only with physical transport. I would say that's even a smaller part of what they've done, but provided a network and the authorities through the participation agreements and the DURSA, it's called, the Data Use and Reciprocal Support Agreement, to allow for this activity to be carried out at a nationwide level in association with the APHL AIMS platform and the public health agencies who receive it as part of a public health disclosure. So you see those health information networks in the center here of this diagram I've been showing you. The right side is actually a public health disclosure that's made in accordance with HIPAA and the state reporting laws that I have alluded to as well. So we package that all up.
Before you go on, John, we have a couple of questions in the chat. One is kind of perfect to talk about right now. Someone was wondering how standardized EHRs are from agency to agency.
So I don't see that question in my chat, so thank you. The eICR and the reportability response are both HL7 standards. We developed those standards. We put a lot of work into specifying them. That does not mean that the EHRs necessarily fulfill them consistently or reliably. And I think the questioner probably knew the answer to this, which is that the EHRs are not as standardized as one would like. So it's helpful to have developed a standard. It's helpful to develop that standard using the common standards process that are used for other purposes, but there's still work here. So what kind of work? Well, for example, there's no requirement that electronic health records need to store lab results in coded form. And that's significant. That's an obstacle. And I would have hoped that came out of meaningful use, but it's not the fact. And so local codes are frequently used when codes are used, and sometimes just string text, narrative text is used. So it's highly variable in terms of the degree of standardization. I think the Office of the National Coordinator is making progress. The FHIR application programming interface is helpful in that regard because it insists that all EHRs be able to communicate using that API, if you will. We took advantage of that in terms of developing the eCR Now app that I've referenced. It connects with the EHR using the HL7 FHIR standard. So is it a perfect world out there? No, hardly at all. Is it moving in the right direction? Yes, but there's still more to do. Was there another question?
Yeah, there was a second one. How many agencies currently participate and how many were involved pre-pandemic? I'm sorry, I did not see when this one came up, so I don't know what people are participating in for this question.
Okay, I didn't catch that. I heard the question. I do like the facts and the expression that's on my chat, exactly the way I feel about the nation's public health surveillance infrastructure being dependent on faxes and manual reporting. The other question is a perfect setup for my next slide, which is on the basis of the eCR Now activity, we moved from having 187 facilities to having basically over 11,000 now that are doing reporting. This is what it looked like during COVID. So at the outset, 187, January 2022, these were just pilot projects and pilot conditions. By January of 2021, we had 6,500 facilities onboarded. This is all occurred during COVID. I mean, if you can appreciate how many obstacles COVID puts in the way, this still occurred during COVID. In January of 2022, 10,200 facilities, and then our current map or very current representation, we have 11,100 facilities that are doing electronic case reporting. Right now, we've transmitted over 17 million case reports, and we are now engaged with 18 electronic health record products that are implementing capabilities either through the app or natively to do electronic case reporting going forward. All of the states and the large local public health agencies have received COVID case reports during this process. And this is one that I'm particularly focused on because a lot of what we were trying to do with eCR Now was to establish the fact that this was necessary, and that there is a viable approach for implementation, because we basically wanted it to be a requirement. We didn't want this to be voluntary. We wanted it to be like the state laws, that they had to do electronic case reporting. And about 5 months ago, CMS put out 2 rules, one for all hospitals in the Promoting Interoperability Program, the other for all eligible providers in the Promoting Interoperability Program, that requires them to do electronic case reporting this year, 2022. So that explains this number, where we have a lot of EHRs that are now in the process of implementing, and a little over half of those are doing that using the app that I mentioned as well. So that was a significant step forward, and a good COVID story, as I said earlier. This is where we are now. You saw where we were then. We've really turned the corner. We now have there are 2 CMS rules that require this activity to be carried out by providers of care, and we're actively engaged with a number of EHR companies that are implementing these capabilities in their electronic health records. The eCR ultimately, with all those wrappings aside, so I've now talked about the legal aspects, I talked about the policy aspects, I talked about the communication aspects and why it's so important to never let a good emergency go to waste, never let a good pandemic go to waste, because these are opportunities for public health as well. But in the end, it's really about the data, and really about trying to make those data in good quality form available to public health agencies so they can carry out their activities. And that's what we're about. We're trying to give broader data, a kind of public health summary, if you will. If you know what a summary record is in clinical care, we deliver what's kind of like a public health summary of important clinical, but also public health relevant information to the public health agencies, deliver that automatically from their electronic health records. And an example is, there's reporting of this. There's the patient contact information, their occupation, race and ethnicity, the diagnoses, the comorbidities, the medications and immunizations, the travel history. This is much more than a lab result. This is about a summary of that patient, and not only as it relates to the immediate problem at hand, but also to try to provide information for ancillary public health surveillance that occurs. So an example of that is MISC. So during COVID, there was a relationship to an outbreak of multi-system inflammatory syndrome in children, MISC. And the way that some of the public health agencies have been monitoring that, identifying it, tracking it, is through these breadth of data that are coming in as part of electronic case reporting for COVID-19. And that's a really important public health function, because frequently it's not the core condition that's so important to track, but how that condition changes and other conditions that are associated with it. And so this is a success story relative to the fact that this system that I've talked to is about and is providing the data that are needed by public health agencies to do outbreak management, to do contact tracing, to work on ancillary conditions that are outbreaks that are associated with this, as well as to track these conditions during an outbreak. And the final slide I have here, and then I'll stop for more questions and discussion, is that getting those good quality data is hard. We already had a question about, well, how standardized are electronic health records? And the answer to that was somewhat standardized, not hugely standardized. What we have to do to bring an electronic health record on board with this program is we test them. We test the eICR, the electronic initial case report that they need to generate for it. And we test it using test data before the EHR even goes into production with their electronic case reporting capabilities. We then test them again when they go into production, and then they're working with wild type data, if you will, that's actually in healthcare organizations in pilots that they implement on their way to full implementation. And then we need to work with them in an ongoing way after they are more broadly implementing, because they make system changes, they do upgrades, things like that happen, and there are needs to continuously test to make sure that the data can be used in the decision support engine that I mentioned to you earlier, as well as at the public health agencies that receive it. And there's a tangible difference here. A lot of exchange of clinical summary documents between electronic health records results in simply viewing that document in the EHR that has received them. So maybe it's a consult, or it's a referral of a patient to a different provider. And then, as much as one would hope that those electronic data can be absorbed into that patient's new record at that new provider, frequently it's simply an image of those data in a sort of like a fax format to make those data available to the new provider. That's not what public health needs to do. Public health doesn't need to just view these data. Public health needs to process these data. Public health needs to apply rules on these data. And that's a whole different level of quality and of implementation assurance that needs to be done to get there. And so it's a big task. We're still, I would say, on the cusp of advancing it nationwide. We estimate that we have done roughly 1/10 of the hospitals that we will eventually need to do to bring them on board in this architecture. And so there's an order of magnitude on hospitals. We think that it may be a slightly larger order of magnitude that needs to be done relative to community providers as well. And we also have a lot of work to do working with the public health agencies so they can consume the data and use them appropriately in their surveillance systems. And another dynamic of something like COVID is that many of them have finally received monies that frankly have been neglected in recent decade for public health agencies to upgrade their information technology so that they actually have capable surveillance systems that can work with these data when they get them in electronic form. So a lot of progress, a good COVID story, and a lot of work that still needs to be done. So I see that a question in the chat. And I welcome other questions to be advanced at this time. Also welcome comments and discussion, but I'll start it on this one. Do public health agencies at larger states, New York, California, and or states with agencies that are under-resourced or politically complicated, drive some of the standards creation at the national level for eCR in terms of driving aspirational goals or bare minimum goals? It's a really good question. And when I was at the CDC, we would fund the states to participate in the standards development organizations. That funding has largely fallen off, so participation now is voluntary. We work hand in glove with the state public health agencies to try to make sure that their needs are represented in this process and in other aspects of electronic case reporting. But it is a very diverse country, and I would say there are maybe 5 or 6 surveillance systems that are prominent. It's not a great market. They all work differently. They all take data in differently. We try to help them as much as we can in that regard, but there's a lot to do in terms of taking what are complicated electronic health record data and getting them into their systems. The question also asks about the politics of this, and it does vary tremendously by state. You'll have large states like Texas where they're very federated, and doing anything across them can be challenging. And then you have small states like Delaware where they're of a size that things can be done in a broader manner more quickly. And there's everything in between those. And so, I think one of the drivers that made us successful during COVID was selling to the public, not necessarily to the states, but selling to the healthcare organizations, that this could actually result in a significant decrease in manual reporting costs. We had an anecdotal expression early on in COVID that in the state of Florida, a large health system there actually was able to redirect 12 people, 12 FTEs that were being used for manual reporting and use them for other purposes because of electronic case reporting. That's a significant number, gets people's attention. Providers of care were champions for this process as we moved through COVID. Reason number one was that they wanted to do the right thing. They wanted to contribute and try to help during the emergency, and that was very pleasing. Reason number two was they didn't want to do manual reporting either, and so they're very eager to get out of the manual reporting business, and they see this as a solution, and it is in that regard. To get that done, we need the public health agencies to accept the data on a state-by-state basis and to validate them as a substitute for the traditional processes they've used. That work is still ongoing. And in a country as big as the United States, with as much variety as the different states, it will be ongoing for some period of time too. But we're engaged in it, we're moving it forward, and I think we have a solution set that can really address that. So were there questions in the other? I don't have necessarily access to the other chat area. Can you help me with those if there are?
There aren't any more questions in our call doc. It's just a Google Doc if you want to check it out. It's the one we've been dropping in chat.
Okay. I'd be happy to answer if anyone has any others, if they want to come on and ask questions verbally, that would be great too. This is a complicated story. I think it's a good story, but it also has many different facets to it.
Yeah, I guess it just like some comments to contribute. Like in particular on the EHR side, like the way it handles data is all driven by billing and events. So like even just to get copies of the data for research purposes later is really tricky. So like this stuff is crazy complicated and really phenomenal that it's been accomplished.
Thank you. It is complicated, and there are some aspects of that are interesting. For example, the latest and greatest technical shiny object is frequently what people want to embrace. There's a little bit of HL7 FHIR that is that. I'm a big advocate of FHIR, but there have been some who have said that any of the existing standards would have worked for interoperability if we had just put enough incentives on their implementation and were strict enough in their enforcement. And I believe in that. I think that is true, but the industry tends to jump onto the next bandwagon, and where that is moving from, in terms of relevance to this process, from the HL7 CDA technology to HL7 FHIR technology. There are benefits in that. It's also, there's hype involved in that process, to be candid. And the majority of the data needs are very, very similar. Clinical care data are complicated, and they need complicated representations to fully take advantage of the nuances that are there. But that's part of the, what we're working through too. And so we have plans, this architecture that's on the screen in front of you is what could be called a hub and spoke architecture, where we have many EHRs and healthcare organizations on the left, many public health agencies on the right, and a single hub in the middle. That's a technical challenge in terms of scaling, but something that cloud technology can readily help with, and that's what we're doing. But it is also a great opportunity. I mentioned the fact that, you know, that EHRs sell into every jurisdiction, and they don't want to develop a separate interface, a separate standard, a separate approach, depending on what state they're selling into. And this allows them a single interface, which then reports to all the relevant public health agencies on the right side for them, without them having to worry about the differing state laws that are in the middle. The other great benefit of this architecture is that it can report to more than one public health agency. And one of the things that happened traditionally is that there would be reporting just where care was provided. But some of the state laws require absolutely that the jurisdiction of the public health of the patient's residence be reported to as well. And this architecture does that. It will automatically send it to the patient's jurisdiction of residence if that's required by their laws. And so that's a great boon for the public health agencies too. And while they are grappling with these new data that we are providing to them, there are also tremendous workflow benefits that will be afforded them when they have full implementation of this. So benefits on both sides. We have now, I think it is 132 conditions that can be authored in this decision support engine, 132. When I started and worked at the CDC back 20 years ago, many of those conditions had individual surveillance systems that were like desktop applications that were given to public health agencies to record their data. So the other facet of this is that this is an integration. It is integrated surveillance. It combines those different conditions using the shared standards to try to make them a viable approach for electronic implementation that would not otherwise be viable. And that's one of the other things that I'm very pleased about, is that we have been able to progress down that road. Public health agencies are not notorious for working together around different conditions. They're kind of stovepipes that develop because of the way funding aligns. It comes down from on high. And so the incentives to share have not always been there for those systems to share, to use common infrastructure, to do things in the same way. Those are not well incented in public health. And what that can manifest itself as, if we're not careful, is differing asks of providers on the left side of this diagram as well. So these are all facets of this activity that really has been the culmination for me of a career, which started with helping to integrate surveillance systems and turned into moving electronic case reporting forward in an integrated fashion. As you may be able to tell, I'm passionate about this and really appreciated the opportunity to talk to you all about it. I'm happy to respond to other questions or close up for the day, if that's the order.
I actually have one more question. Just like you kind of alluded to the funding, but like I'm just thinking, like I'm here in Cincinnati. We're a somewhat big city. We're not like Chicago that has huge kind of infrastructure, and open data initiatives and things like that. I mean, how do these smaller organizations, cities, municipalities get access to funding to improve their infrastructure? And is that, or does this become some like unfunded mandate in a sense? If it ever became a requirement, they would need that funding.
Yeah, you touched on a number of things that are really important. And the first one, I would say that electronic case reporting is a requirement now of healthcare organizations, not necessarily of public health. Number two, that the public health agencies do receive funding from the Centers for Disease Control and Prevention, because the way that public health funding works is it's basically allotments from Congress that come down to the Centers for Disease Control and Prevention onto the states, and at times directly to the locals, but also through the states to the locals. There are over 2,400 local public health agencies in this country. And as expressed in your question, some of them have more resources than others. In fact, COVID is this phenomenon of funding that comes during an emergency is what we're riding in right now. So there was over $12 billion that was put out in public health or through public health as an outcome of COVID. And that's an astronomical number compared to what public health usually gets. You actually will hear public health agencies right now saying they don't want more money because they have to carry forward on the monies that they've now received. The traditional problem is that that doesn't sustain, right?
Mhm.
Monies flow during the emergency, and then when things become calmer, like hopefully the phase we're going in with COVID, that over time those monies will diminish. And that's a difficult way to support consistent infrastructure that needs to be in place. You don't want to be implementing this infrastructure during an emergency like we did. You want it implemented before the emergency. You know, one of my laments in this regard is that we didn't have eCR fully before COVID. We had to use COVID to get to eCR. We made progress in that regard, and I'm very pleased about that. But in my ideal world, we would have already implemented it. And then that has to be maintained, and it has to be upgraded and progressed. And those funds have been dwindling in public health coming into COVID. And so it's not where we are right now. The money is flowing. If you want to say it this way, it's sloshing around in public health because it is finally getting the money it needs to implement it. The unfortunate part is, or the question is, how long will it last? And will that sustainable funding be there a year from now or 2 years from now to carry out this infrastructure?
Thank you for that.
Sure, really good questions.
And I also don't see any more questions in the call doc or in the chat, I think. So I guess if there aren't any more questions, we can go ahead and wrap up for today. We really appreciate your time today, Dr. Lunsk, and the information that you shared and the vision that you also gave us to hopefully be able to get more infrastructure put in place. So,
well, thank you for having me. I enjoyed the conversation.
and check out the CARC website for the upcoming events. And we'll see everybody on this track next month. So, thank you.